Yes,
Look,
we could probably go ahead and get going. Hello, everyone. Thank you for joining us tonight. We're so excited. We're so excited to have Dr. Shah with us today. A lot of you know him. He's a glaucoma specialist and a surgeon at the University of Michigan's Kellogg Eye Center, where he focuses on caring for patients with complex and advanced glaucoma. Dr. Shah is not only a talented clinician and surgeon, but he's also deeply involved in research and innovation, especially around new diagnostic tools, MIGS procedures, and advanced treatment options. As a glaucoma editor at the iWorld and moderates the ASCRS Symposium. We're so lucky to have him here with us today. We're really grateful, and I'm so excited to hear him talk. Thank you, Dr. Shah.
Wars. So good to be here, team. After a fun OR day, needling blebs and putting little micro stents in, it's nice to talk about. There's nothing complex about this technology, but I would argue that the data we're generating through home tonometry is really starting to change how we think about glaucoma. It's certainly changing how I approach challenging and complex patients, or rather straightforward patients, as the case may be. Yeah, hope to discuss a little bit about how I use home tonometry, and we have 4 of my own patients over the last year. So this is not like we didn't go dig through the archives here. These are just 4 of the patients we've hooked up with home tonometry through MyEyes over the last year, and the data we generated really had a very profound clinical effect. And yeah, this is me. Ashley's gone over it. You guys know who I am and can find me, but I'm happy to work and teach at the University of Michigan here in Ann Arbor. I've been back in Ann Arbor since January. I've been back and forth a little bit, but Michigan's a great place to call home, and happy to have any one of you guys want to come out and visit or reach out. And disclosures here, I found out just as we were doing these talks, I'm getting an honorarium, so that's cool. But honestly, I'll spend a second here because this is a technology and a service that means so much to my patients and me that it's just a privilege to be asked to help spread the good word and share what we've learned. So with that, let's talk a little bit about a pressure fluctuation and glaucoma. So we know that glaucoma is a disease of intraocular pressure. That might not be the whole picture. In fact, it's much more complicated than that, as we know, but pressure is the thing we can do something about, so we care. Sometimes I think that spot check we measure in the office, I think we care a little too much about that. And we see our patients kind of latch onto that number. What's my number today, doc? Oh, it's 15, but it's supposed to be 13. Am I in trouble? We really focus on this one data point because that's like all we have, right? Every other data point we generate is either subjective or it's mixed with a bunch of artifact or doesn't tell a really cohesive picture. But IOP, man, that tells you something, right? If the pressure's 30, that's bad. And if the pressure's 9, that's good. And we are very quick to stop there. But we know, as folks who treat glaucoma, even if we latch onto that number ourselves, we know how relatively fickle that number is, right? That number, that pressure fluctuates. We know pressure fluctuates in all creatures, and we know that it fluctuates more in folks with glaucoma. This is well established. What we also recognize is that the presence and potentially magnitude of pressure fluctuation can correlate with progression of disease. We saw this demonstrate itself to be an independent factor for progression through multiple studies. The study that comes to mind to me is the AGES study, in which we saw that people with high pressures progressed, but people with normal pressures but high fluctuations progressed at the same level as people with high pressures. So it's obviously, I don't think we need to reinvent the wheel here. If the pressure's really high, get it down. That's how we treat glaucoma. But our work doesn't stop when the pressure's low in the office because it could be dancing around, and that fluctuation in and of itself can be linked to progression of disease. And this is that difference between if the pressures are high, yeah, that signal is so overwhelming, you just got to get the pressure low. But when you dig deeper, when you look at other studies in which we follow these glaucomas out a little bit, those controlled but variable pressures are still contributing to disease progression. Now, there's a lot of why behind that. Is it that those intermittent peaks and troughs cause problems? Is this sort of a secondary marker for poor adherence to Medicaid or inadequate treatment or what have you? I think the answer is maybe yes to all of the above. We are starting to be able to finally, even though we've known for many years that IOP fluctuation in folks with glaucoma is a real thing and it's a clinically significant thing, but we've been limited in our ability to really identify it, right? We can do a diurnal curve during the office day, which is something, but it's not everything. And it is truly with technology like home tonometry that we can actually dig into this data. And again, I'm going to share some patients of mine. We recognize that postural changes in pressure, normal circadian cycles in terms of when certain pressure raising or lowering factors and humors in our body play a role, as well as timing of medications, if and when those are being done, to make such clinically impactful decisions based on a very small data set that may be only covering at best, even if you're really vigilant and have the patient show up in the morning one day and mid-afternoon one day and last patient of the visit the other day, you're still only capturing 8-9 hours out of a 24-hour cycle, and that's assuming that they're staying stable over that time. But we know that even the diurnal cycle can fluctuate up and down a little bit or shift over in time. And so we have these clinical conundrums. We have these normal tension glaucoma patients who are progressing despite our best efforts. And when we are in an era now where we have such a robust toolkit in terms of our surgical and laser-based offerings for patients that can really now we can really start to identify disease before it causes problems. We can intervene in ways that don't interfere with quality of life, and we can really maintain a patient's visual and just overall satisfaction in a way that we really couldn't decades earlier. But critical to this is really understanding the disease we're fighting, right? And utilizing the right tool for the right job. If you indeed have a patient who's progressing at a pressure of 12 and it's really happening, then man, despite all the technology we have, we're pretty limited in the toolkit insofar as controlling that patient's pressure. But if that person is 12 in the day and 30 every night, that's a different ballgame, right? We don't need to drive that pressure to a sub-physiologic and risky place. We might be just talking about steadying this person out. Very different surgical option set, very different downtime and risk factor profile, and again, effect on patients' quality of life. And again, we recognize that these fluctuations are intrinsic. These are physiologic things that might be broken down. And we know that in other chronic medical conditions, we do better by having this relatively real-time data. No one, I hope, is diagnosing and treating diabetes based on one random finger stick every few months, right? No way. That is not okay. Even something that integrates data like an A1C, that's not sufficient. We need to actually know what's going on in real time and use that to make decisions. And that's how we deliver high quality and patient-centric personalized care. And recognize again that with the treatments we have, not everything controls pressure at all times. So prostaglandins and CAIs have been demonstrated in older studies to continue to work at night, but alpha agonists and beta blockers really seem to not. Again, these are older studies. It might be time to reinvent here with our more robust technology, because these were old studies done in sleep labs, basically. But so now that we have the data, we're starting to see, and we have new classes of medications that didn't exist at the time that these data sets were generated. So we're starting to dig into some more of these basic first principles questions. What we also know from some literature is that surgical intervention, whether it's laser-based or true operative room surgery, these have more profound capacities to stabilize pressure, not just reduce, but also stabilize. And the jury's out still in terms of how we quantify this definitively. What's normative? What's abnormal? What is a sufficient change in fluctuation parameters to solve that issue? How individualized is this versus not? But again, these are exciting questions that we're going to be asking of ourselves and our community of glaucoma specialists once we have this data more comprehensively available to us. The method of tonometry here with the iCare is this rebound tonometry. I think many of us have used this technology in our clinics because it's very safe, it's very comfortable for patients, it's validated. Is it the same as Goldmann? No, it's not. Is Goldmann, when you do Goldmann applanation, are you getting the true intraocular pressure? No, you're not. It's an assumption, and all of these assumptions are predicated on the fact that we're squishing a ball and trying to get a feel for what is squishing back at us, what is pushing back at us. We recognize that the material properties of the wall of the eye are going to play a role in what that rebound pressure is, whether it's through conventional applanation or rebound tonometry. But we do see that even if there's not one-to-one correlation, a pressure of 16 on iCare may not be 16 on Goldmann, but a delta of plus or minus X numbers is preserved across technologies. So we don't need it to literally tell us what the pressure is in the eye. We need it to show change, a much easier thing to do, and I would argue a much more impactful thing to do. So again, this is the iCare Home. It's designed very easily to be measured by oneself. I've only had one patient in many years now of using iCare Home who's truly been unable to, and that's because they had lost fixation in that eye. So they couldn't see the big fixation target. One patient. And let's be honest, at that point, if you've lost fixation in the eye, we are probably not worried about pressure fluctuations. We have a bigger elephant in the room here. But for most patients, and again, this is technology, and we know that most of our patients are in the older decades of life. Sometimes using something with a screen and buttons is a little daunting. Again, I've been so satisfied and surprised by the fact that routinely patients are willing to obtain this data. They are encouraged by this. They feel ownership of their disease in a way that they hadn't before. And they invest in learning how to use this and really routinely give me really good data sets, which demonstrates that they're learning how to use it and taking control of it. And I should add that the good folks at MyEyes are phenomenal in getting patients geared up for this, whether it's coaching them through how to use it, providing them with all the supplies they will need, and just being reliable folks to troubleshoot things during the days that they have rented this device. I have had unprovoked, glowing comments by my patients about the service that MyEyes provides when they're going through this journey. Again, that's purely not part of the slides and is unsolicited, but I want to share that feedback on behalf of my patients who've been so happy working with this company. We see that these pressures fluctuate often early in the morning. I'm going to show you some great examples. And it's typically like before clinic starts, and I've never been accused of showing up early to clinic, that's for sure. And I somehow can't convince my fellows to start that 4:30 a.m. pressure clinic yet, but it's a new academic year. We'll try again, but it just doesn't happen. And we're never going to capture this data. And these data can really change how we think about and characterize this disease. And we see these folks who have these rather dramatic spikes. Where do I use home tonometry? I want to first and foremost understand the disease I'm treating. If I see someone with glaucoma and I look at their nerve and they have characteristic optic nerve changes with characteristic field changes or OCT changes, they have the right history, they have the right everything. I want to know, Again, if they're walking in the door with a really high pressure, I'll be honest, I'm probably not using home tonometry. I know what the game is. They have a high pressure, we got to get it down. But the people who are, they just don't, it doesn't feel like they're controlled. Whether we can see changes, whether they're describing these fluctuations, doc, I wake up with really blurry vision and I get my drops in, it takes an hour or two before I can see clearly again. Is that pressure up before you woke up? So if I'm hearing things on history, if I'm seeing things on exam, disc hemorrhages, field progression despite good adherence as far as we can tell and normal controlled pressures, then we gotta really understand the game because again, where that pressure is and what's happening really is going to dictate what surgical tool is going to be best for this patient. Again, if they're progressing despite well-controlled and stable pressures in the low teens, they probably need a trabeculectomy. I don't want to give medical advice here, but we don't have a lot of technologies that are going to get the pressure that low to sub 10, sub 9, as our normal tension glaucoma study describes in terms of getting that 30% pressure reduction in progressive NTG patients, right? So if that's the game, we only have a couple tools that will really win there. But if the game is stabilization, as we saw earlier, there's a lot of ways to achieve stabilization, whether it's laser trabeculoplasty, canal, MIGS, standalone or in combined cases. We might not need a trabeculectomy. We might opt for something less invasive, like a microinvasive bleb forming surgery, et cetera, et cetera. We start to go back to the playbook here. And then we also recognize that monitoring is valuable because, again, that static one-off pressure is not going to tell us the whole story, especially if we use this to judge the efficacy of some of our therapies on the positive side, or if they're starting to wane, if we have time-limited things like sustained drug delivery or laser trabeculoplasty, where we know at some point that effect is going to peter out, we might not have to bring the patient back every 5 minutes to see, hey, is the pressure up yet? Is it up yet? We could potentially leverage some of these technologies and allow patients to obtain that data for us in a very comfortable way. I like to share this data. I think it's really cool that patients get it too. They might not know what to do with a very noisy data set, and we're still figuring it out, but I like to share this with patients so they know the game that we're playing. If things are stable, hey, high fives all around. If things are fluctuating, let's work on that. And now we have something that we can all see on the screen that we want to make better. And again, I think it is really empowering for patients to see what I'm seeing. I like showing I like teaching. I'm a teacher. So I like showing my patients their visual fields and their OCTs. And I think showing patients their pressures, their pressure profiles is actually really powerful too. I can't prove this, but I got to imagine if they're seeing that pressure fluctuation and they know, Jesus, because I'm not taking my drops, that's got to be a positive motivator without being I don't like wagging my finger and say, do better with your drops. I think people don't want to hurt themselves and they struggle with drops, but sometimes this little push can be really powerful, as can that conversation, that collaborative decision-making insofar as offering more definitive treatment options. Hey, look, this is what's going on. For that reason, I'm recommending this. And we end up being more active in the care. Both the physician and the patient are more active. And I think in glaucoma, we've inherited sort of a dogma of being a little bit more reactive than proactive. We're waiting to see field progression or OCT progression or something like that. But now that we have such a robust set of relatively safe interventional strategies, the onus is on us to perhaps move things up a little bit and be proactive when we can. Not always, but certainly having data like this that demonstrates effectively the writing on the wall, your pressures are all over the place. We know where this story is going to go. It empowers us to have a reason for taking that next step. It's also nice to look at pre and post data, right? So I'm going to share one of my patients' pre and post SLT, pre and post repeat SLT, I should add, because we can just compare apples to apples here. No other interventions, just this. Let's see the effect of this. Again, patients love it. And I, as the physician, it just makes my decision-making a lot clearer. Did it work? Yes. Okay, cool. Let's watch it now and see if that works insofar as controlling field, OCT, etc. Did it not do squat? I'm not gonna sit here on a hope and a prayer that maybe I did some magic that the IOP curves aren't demonstrating. We're gonna move on without waiting for fields and OCTs to progress. And lastly, I think we can probably sit around the table and come up with a million use cases for it. We have a lot of patients here in Michigan who don't live anywhere near Ann Arbor. And Ann Arbor, or this 100,000 person town, is the big city that people don't want to go to. Great. We can do a lot of monitoring closer to home for those patients. We can, again, empower them to not have to contend with the challenges of coming in and out of long visits and long commutes. And the other example I'll give is identifying patients who may not have glaucoma, right? They might not have an IOP dependent disease process. And it is really a huge relief to these people to tell them they don't have this chronic disease that may make them go blind, and that requires care and monitoring for the rest of their lives. So that can be a huge impact. Fundamentally, we are going to have to be creative with how we deliver care for the glaucoma patient, because there's more glaucoma patients coming and there's fewer glaucoma treatment providers coming. And this is a frightening graph. That's granted, it's an approximation and a speculation, a projection, but it's not looking great for people my age. If we get glaucoma, God forbid, our workforce projections are tough. And you know that monitoring chronic disease is not as sexy as taking out a cataract. And so even these workforce projections may not fully encompass the challenges that our glaucoma patients specifically are potentially facing. So we got to do better. We got to be more efficient. We got to deliver care in a more personalized and more effective manner. We can't do one size fits all medicine. It just doesn't work. And so in an effort to do better, here are some patients. But fundamentally, when I'm describing obtaining home tonometry for patients, what I tell them is, look, I want to understand your disease as much as possible. By virtue of being at a university practice, we typically see second opinions and third opinions and fourth opinions. And these are typically patients who are struggling with their disease. They aren't necessarily part of the 80% who pressure's high, it's come down, they're stable, good to go, see in 6 months. We're focusing on the edge cases, but quite frankly, whether you're in a university, in a tertiary care center or not, the easy ones are easy and the hard ones are hard, right? And we need to do better at delivering great care to both, but certainly the hard ones. And again, I describe to patients that your eye always got a pressure to it, and that pressure fluctuates with every breath, with every beat of your heart. When you move from lying to standing and back, it's always changing. And we need to understand to what extent. We need to really understand your eye before we're going to do something to optimize it. And I'll tell you, it's a pretty easy sell. I don't think of it as selling, but I think it's a pretty easy sell because patients are enthusiastic about understanding their disease when given a way to do that that's relatively easy. In terms of how I coach them to use this, I tell them I typically do a 1 to 2 week rental. And I say, for the time you have it, try to get a measurement every couple hours while you're awake. And then while you have it, give me a couple days of late nights, a couple days where you wake up early, and a couple days where you wake up in the middle of the night and set an alarm. And if you happen to wake up in the middle of the night to go to the bathroom, shoot a measurement while you're there. So over that 1 to 2 weeks that you have it, we will aggregate all of that data. So we'll have a sense of what your 24-hour profile looks like. And that's a very easy thing for people to handle. And again, routinely, we get great data out of it. So here's some cases. Case one is probably my most dramatic one. And we don't have a post on him yet because he was a patient I took care of when I was on faculty in New York. And I left like about 9 months ago. So I don't know what the end of his story is, but we're going to hopefully find out one day. So this is a young man. He's not even 30 yet. He was referred to me from the School of Optometry where he had been getting care because he was progressing and he was on everything. This guy was on every topical agent. He was not on orals yet. And his OCT, fortunately, his fields as a young man, his fields were still relatively intact, but his OCTs continued to progress despite clinic visits routinely in the low to mid-teens. He had SLT once, but as you can see, and again, these were rather dramatic readings, and he, to his credit, got a lot of data. So this was back in April of last year. He had it for a couple weeks. He got 100 measurements to his credit. And you can see pretty consistently, he would spike to the high 20s to low 30s every morning. Every morning between 3 and 6 a.m., he was in the 30s, and all day afterwards, he was in the teens, even as low as 9 and 10 and 11. So this is not someone who's chronically high. This is indeed someone who spikes and comes right back down. And we have more data here. We had done an SLT here between visit 1 and 2 in an effort to try to try to take the edge off. It took a little bit of the edge off, but not much. But man, how useful is this to compare and demonstrate again that we're not quite getting there. And we did get more data on him. He got one more study just as a comparison. This was right after I left NYU, which showed that he's still doing this. And as last I heard, he was being set up for canal surgery. Again, his fields had not progressed. His OCT was progressing a little bit, but his pressures were the main driver here over the 6 months or so that he was under the care at NYU. Fields had not progressed. OCT was a little unstable, but not dramatic. But these pressures were a driving factor to take that next step. This is a patient, and I'm just going to go to my notes to make sure I have her properly here. But this patient is a patient who doesn't have glaucoma. So she presented to me with an optic nerve defect and a visual field defect that had been present for a long time. She has a family history of glaucoma. She was seen in our comprehensive ophthalmology clinic and sent to me because obviously she had glaucoma. It was purely unilateral, not to say that glaucoma can't be unilateral. Her nerve didn't look cupped to the degree that the field was demonstrating. Basically, it didn't look like glaucoma to the glaucoma specialist. Now, could it be glaucoma? Could this be an IOP-mediated optic neuropathy? Absolutely. But something didn't quite seem right. And so we obtained home tonometry. And what do we see? She peaked at a 16. Her lowest was an 8, or 16, 17, lowest 8, 9. She's pretty stable, guys. Like her mean pressure is subnormal with not a huge deviation. This is not necessary. Now, again, this could be someone with really weird NTG that's particularly itchy and progressive, even though she spends very little time in the mid-teens. But what we also see is the pressure curves are rather symmetrical between the two eyes, yet the disease was very asymmetrical. I sent her to my retina colleague, say, hey, find something back there. And sure enough, she had very tiny peripheral blot hemorrhages that were only identified on wide field imaging. And unfortunately, they did get an FA, but there was some artifact on the early shots. But in late shots, you could see that there was some areas of atypical non-perfusion of the retina. So the suspicion is this is some sort of a vascular issue and not an IOP issue. And she's getting more workup with our retina and neuro-ophthalmology services to figure out, hey, where is this perfusion defect and what treatment is indicated? But certainly this is not someone with an IOP-mediated process. Again, if she was progressing at these pressures, we'd be talking about trying to get a mid-single-digit IOP target, right? That's what we're going for. And that's a pretty high risk and a pretty kind of a big deviation to take in someone who may not have a glaucomatous process to begin with. This is another case of mine. She's 60 years old. She refuses to answer. She's funny. She refuses to answer where we have to ask name and date of birth when we check a patient in. She will not say the year. She refuses to acknowledge her age. She's a funny one. So I hope she's not on the call. But she had SLT by my fellows about in late 2024. And objectively, it looked like it worked. When I inherited her in February, her pressure was basically back to her pre-laser baseline, but she was not a high pressure kind of gal. Seeing that, okay, a couple months ago, the pressure was good. Today, it's not. Am I just catching you on a bad day today? Did they catch you on a good day last time? Let's see what you're doing right now. And if you got a lot of action there, we might do another laser. So here we go. This was her first round. And we see that she is indeed doing that morning spike thing, right? She's not going super high, but she hits the 20, 21, 22 pretty consistently. And her mean, you can see, is in the mid-teens, and her standard deviation is about 3. So we did another round of laser. And again, fortunately, this is someone who's pre-parametric, has mild glaucoma. She was having optic nerve changes when she looked like this. And so we did another round of laser, and here we go. With the exception of one couple readings here, we did flatten out that curve a bit. So certainly she does get to 19 and get to 17, but not as frequently. I'll go back here. So here she was crossing over that 20 threshold a little bit more consistently than she is now. The peaks are down and the standard deviation is down too, from about 3 to about 2 to 2.5, as the case may be. So we've done both. We've brought down the top end. We've also steadied things out. And so now we're in the monitoring phase, but I see this, again, this demonstration of a real effect at stabilization and pressure reduction. Now I got something I can hang my hat on to confirm. I saw her over the summer and her OCTs had not progressed any further. Obviously, we're going to continue to monitor this to see if this is good enough. This is still unknown. This is uncharted territory. If this is an adequate enough diurnal stabilization to protect her. And I'm sure this is individualized, but certainly it's nice to see that we made a difference from scan 1 to scan 2. And here's my last patient. This is an odd one. He's a young male. He had a history of trauma in one eye. He has glaucoma in both. And he's the guy, he's very hesitant to have any surgical intervention. He refuses to have laser trabeculoplasty. He wants to use eye drops. He does his eye drops pretty consistently. And I was trying to get him off drops, and he's on everything, including pilocarpine. And I'm like, man, you don't need to be on pilo. You're a 49-year-old myopic male. We got to do better than this. He wants his pilo. I said, okay, let's get some home tonometry and let's play with it. This is a guy who is very well educated, very motivated. He's very dialed into his care. I said, look, pilocarpine typically washes out in just a few hours. You'll know if we don't like it. And so here's his data. Again, he was very diligent in collecting a lot of data for us here, hundreds of data points over time here. And so this was a baseline assessment. He's reasonably stable. He does go into the 20s occasionally, but his standard deviation is not too bad. His means aren't too bad. And again, he has not been progressing. But what was interesting is here on this scan, this is what we got that first study. We said, hey, look, things look pretty good. We have a little bit of room to play. And over the summer, we tried to play here. In his right eye, we had him stop his pilocarpine. He stopped it on the 26th, okay? And he started measuring data. It took until almost the end of day 27th for his pressure to spike. And if we go back to the previous scan, he never crossed into the even upper 20s, much less 30. And sure enough, we held the pilo for a day and a half, and then his pressure went up, which is not what you read it's not what you would expect necessarily in terms of that duration of effect. He spiked, he said, oh, I don't like this, went right back on pilo, and boom, went right back to those really steady diurnals. So for him, there's something special about pilocarpine specifically, or pilocarpine in the context of his other medications, that really provides rather impressive diurnal control. Again, for a medication that has historically been dosed every 3 to 4 hours for a reason, it seems to, for him, be that missing thing that gets him to a level of diurnal stability that I think is going to keep him out of trouble unless his ocular surface suffers. But so far, he's happy to continue on medications. And he's empowered knowing that, hey, look, he's on the right regimen, because when he tried to get rid of one, his eye didn't like it. So again, these are just a few different examples, whether it's diagnosing challenging or progressive disease, to even answering whether this is glaucoma, whether it's titration of medications. And you can imagine the sky's the limit in terms of really personalizing topical therapy, to identifying the true effect of some of our therapies post maturation, as it were. There's a lot of ways that we can use this data. And so I encourage you try. You're going to be shocked at what you find out. And the challenge certainly is determining, hey, what's normal and what's abnormal. And in without really knowing the answer, and my best guess is there is no such thing as normal and abnormal. There's probably a normal for a patient, and we are going to just have to learn to hopefully tailor our care to a degree of optimization. We might not have yet an answer as to when we've arrived, but the hope is with more and more data being generated, we will be able to determine what normative diurnal fluctuations look like and what desirable ones look like. So again, there's a lot of challenges here, whether it's ownership of disease, understanding the disease and pathophysiology, understanding compliance and adherence, and then dealing with the demographic changes we're facing. We have to do better. We need tools that do this. And I would argue that home tonometry is really powerful. So with that, I'll turn it over to Ashley to talk more about what MyEyes specifically brings to the table. Happy to take questions after, but Ashley's going to know more answers than me.
Thank you, Dr. Shah. That was wonderful. If you can go to the next slide. Thank you. These are the 3 different options we have for the patients. So the first one is what we call our Diagnose. It's a weekly rental, a short-term monitoring package. We call it Diagnose because a lot of the times patients come in, you don't know what's going on. Let's rent this home for a week and get some answers and then figure out where we want to go from there. So for the first week, it's $249. And then for the second additional week, it's $150. We came out with a new plan. We talked to many doctors, including Dr. Shah, to pick their brain and see if it was worth it to create this new rental program. It's called the Compare. So you would rent it before, you decide on what kind of like procedure, medication change, laser that you would want to move forward with, get that baseline, if you will, decide what you want to do, have said surgical procedure or laser, and then depending on what the doctor would want, 6 to 8 weeks after that is completed, we would send the home tube back to the patient. And that way, kind of like Dr. Shah was saying, you have this true apples to apples comparison of whether whatever action you took actually worked. So it's 2 separate rental periods. So it's $399 for both. And they have up to a year to use that second rental. And then obviously the patients can always purchase the device as well. So those patients that are very involved in their medical care and kind of want to know what's going on, they can purchase the device for $2,995. We do have payment plans for rentals and purchases. Patients can use their HSA accounts, FSA accounts as well towards the device. And then also we're seeing more and more insurance companies reimburse. So we're a preferred vendor with United. And it really is just dependent on that person's specific plan. They can always call their insurance company and ask if they have DME coverage before they proceed with the rental or the purchase to get an idea of what they would be looking at. And then we support them with all the documentation that they would need, all the codes, answer any questions, really hold their hand throughout that process as well. And if you can go to the next slide. And then we can probably just go to the next slide. So the remote eye care services that we offer, 24-hour home IOP monitoring, and then obviously the research. We're really involved with helping move the needle forward, if you will. We want to get this into the hands of as many patients as possible. And we know that the more doctors prescribe it and the more studies that go on, it's only going to grow and take off, and the more insurance companies will reimburse. We're moving in that direction, which is really exciting. Every month we just grow and grow, and it's incredible, really. You can go to the next slide. So how it works, it's really simple. Doctor goes online to our website, myeyes.net, They submit their first prescription. Moving forward, you will have a login after you do that initial one. The patient, we can either reach out to the patient or the patients can reach out to us. They can go online or they can call. It's kind of 50-50 with this patient population. A lot of them still like to call and use the phone. We ship it out to the patients within 24 hours of that order being placed. We ask them, are you going to be home during this rental period? You're not going on vacation, no distractions. Really want to make sure you have the time to dedicate to getting these readings. We onboard the patient, so we will call them the day after they receive it, and that's where the rental period starts. And we make sure that they know how to use it and they can get accurate readings as well. Once they are done with the rental period, then they put it back in the box and they put the return shipping label back on and it goes back to us. We download all the data and then we send the doctor a report once we get that. Then you can reach out to the patient, say, let's set up a time either remotely or come back to the office and go through what you found with them. Next slide. So we've served over 2,200 patients. Our customer service, that's what we do, is through the roof, 95% customer satisfaction scores. We have our patient ambassadors who have glaucoma themselves, are the women that reach out to the patients, answer any questions, walk them through start to finish of using the device. Just really empathetic, really knowledgeable. They use the device themselves. The patients love us. I think anyone that's ever used our service would really speak highly to the fact that we take how we serve the patients very seriously and we do it well. And then we also work with Harvard and Duke and NYU. So a lot of these big names trust us with their patients, which says a lot. And obviously Moran work a ton with them. Hey, is that the last?
But Kellogg Eye Center right there at the top.
Kellogg! We got to move it up.
Right. Come on.
Yeah. Yeah. And yeah, I mean, thank you for logging in. Dr. Shah, like you said, can take the questions. But if you ever need anything or have any questions, please feel free to reach out. My email is ashley@myeyes.net. And whatever you need, love to help you in any way that we can. Do we have any? Oh, I guess, I don't know if Megan, how we want to do question answers. We just unmute people or they can raise their hand. Unmute. Okay. Does anyone have any questions for Dr. Shah?
I actually do. Thank you for such a wonderful webinar. Dr. Shah, I was just curious about patient or case number 2 that you shared in your presentation. If the patient was on GLP-1s, you mentioned that with the solution, the device, you were able to acknowledge that the IOP related causes wasn't actually impacting the retinal defect. And I just was curious if we were looking at a case of potential, like a Nyon type of case, or what you were able to glean following up with that patient.
Great question. No, she didn't. Interesting. She's not on GLP-1 to my knowledge, but nowadays people are getting them, go online and get them. So it's even showing up on the med list. So we didn't query that yet, but it wasn't on her official med list. No, she had no other sort of vasculopathic risk factors. It's like a very active 57-year-old who looks 40. So it's very atypical. So no, we haven't found anything yet, but it's an odd one, and I'm glad I'm not doing a trab on her. Yeah. I'm gonna dig into her chart and see if anyone has answered that on GLP-1 specifically. I don't think she was on one, at least officially prescribed.
Fantastic. Thank you.
Thanks for the suggestion.
Hey, Manjool, this is Sanjay here.
Hey, my friend, how are you?
I am good. I'm sorry, I'm driving back home from work. So just wanting to actually ask, first of all, fantastic talk. Thank you. Thank you for
Thanks.
sharing all this information.
You've done a lot of that's gotten us here in terms of IOP fluctuations and whatnot. Thanks
you for moving it forward too. Yes. I had a question for Ashley. Ashley,
Yeah.
how do you train the patients in its use? Is it a video call? How do you do?
They can do either. They can do, if they want to do a video call, they can do it that way. A lot of them just do it over the phone. Some are able to do it on their own. Some need another person to come, a child or a caregiver that come and help them while they're learning how to use it. It just really depends on what that patient wants, and we make it happen.
Like, how do you adjust the patient's adjustment of how close they need to be or how far they need to be without video?
I know a lot of them do it without video, and they're able to do it because we see how successful the readings actually are when we get the data back.
So I'm one of the patient ambassadors for MyEyes, and basically the machine knows where it is in space and time. It won't take a measurement if it's too close, and it won't take a measurement if it's too far. So it's just a matter, honestly, most of the setups are done over the phone, if you can believe that, with some very technologically challenged patients. And we get them going. Sometimes it takes a little bit. It takes a while, but we get them going. We get them up and started. And it's just a matter of adjusting, just like Dr. Shah said, just adjusting the legs and going one at a time and moving it in. It's a little bit of a process, but we walk them through, and we have a 97% success rate in getting patients up and running.
Yes, I'm amazed at the success rate.
Yeah.
That's why I was curious as to how you trained them. And thanks for sharing that they are able to do it over the phone, most of them. Thank you.
Yes, I'm actually amazed too. So there's some that you're just like, they're not going to get it. And suddenly they get that measurement and you're like, you're good. Like, you're good. You've got it. And it's just, I think sometimes it's just the trepidation of taking a measurement. And once they do it, they're great. And then you have them getting up in the middle of the night. And I was the same way. I was a renter to begin with too. You get up in the middle of the night, you're a pro. So it works really well.
Thank you.
Thanks, Sanjay. Exactly. And please feel free, Ashley, you can feel free to distribute my email. It's my first name,
Okay.
manjool@med.umich.edu. Feel free to drop me a line if you have questions about this and what am I looking at here. And by no means am I an expert. I'm in there with you all. I'm just getting the data and trying to make the most sense of it, but happy to collaborate. That's what we do. And I think when we're working together, we're working at our best. So I'm happy to, perfect. So don't hesitate to reach out. But thanks for hanging out this evening, guys, at the start of the week, much less. Fundamentally, this is it's great tech, packaged in great customer service, and it's changed my practice, and I think it can change yours, and it enables us to do what we strive to do that much better.
Thank you so much, Dr. Shah. We're so appreciative of everything you do for MyEyes.
Pleasure. Thanks, everyone. Thanks for hanging out.